Okay, so this is my first case, and this is an interactive case, so I want you guys to try to give me some diagnoses. This is just a patient with mild abdominal pain. She was 51 years old, and she showed up with this lesion here in her upper abdomen. We can see it's a lobulated lesion. It's interfacing with the stomach here. It has some calcifications. And it's also intimately affiliated with the pancreas. So we can see the pancreatic head and uncinate head here. And then it's kind of replacing or at least squishing the middle of the pancreas. And then the pancreatic tail is normal. So any guesses so far on what this could be?
I think I want to know if in terms of ROI, is it like a soft tissue or is it cystic? I guess on a T2, maybe it is cystic.
Great. So you're asking
with calcific.
Yeah, so we only had one phase of contrast, so post-contrast,
yes.
And so we couldn't tell if it was definitely enhancing, but it measured like 30, 40 Hounsfield units, so it didn't look definitely cystic, at least here. I didn't have the MRI. I shouldn't have shown you the MRI yet. Online, people are saying, Kavya saying serous cystadenoma, so that's a good thought.
Last time
we had that good mimic.
Exactly, I want to say because of the calcification, and if it comes from, especially from the pancreas and cystic, we could think about a serous cystadenoma.
Exactly. Amr asked about a SPEN tumor. Good thought. Gitanjali said mucinous lesion. Lori said pseudocyst. I would say this looks a little too complex for a pseudocyst, and the rest of the pancreas looks normal. It looks like there's more complexity here. And then Anu said some kind of mucinous tumor. Okay, so I'm going to show you the MRI. So on the MRI, we can see that it has a lot of T2 hyperintensity, but doesn't necessarily have the microcysts that we're used to for serous cystadenomas. And it had quite a bit of enhancement. So it had a lot of internal enhancement. And then the biggest clue was actually on the pre-contrast. You can see that there's areas of T1 hyperintensity, suggesting that there's hemorrhage within this lesion.
Could you think about a neuroendocrine?
Excellent. So that's what I was thinking based on like at least the CT, given the degree of calcification. I was really favoring a neuroendocrine tumor. It looked like it has hemorrhage in it. It has a lot of enhancement. It's pretty T2 bright. So the biggest clue is this hemorrhage. So are any of these, so say you saw like a solid and cystic lesion that also has hemorrhage in it. Does that ring any bells for anyone? Yeah, so Gitanjali said it's a SPEN tumor. So I didn't pick up on it initially with all this hemorrhage. I really was favoring a neuroendocrine tumor. We ended up biopsying it. So here was our lesion, and we did a transhepatic biopsy here, and it came back SPEN tumor. So a couple of points about all of this. So one, we did this pancreatic biopsy transhepatic, which is pretty safe. We wanted to find an area that looked more solid appearing. So maybe back here it looked a little bit darker. So we were saying, okay, this area looks good. So we used this calcification as a reference. We also wanted to make sure we weren't going to be traversing any major branches of the portal vein. So we chose, and not hitting any of these subcutaneous vessels. So we chose this kind of route using that calcification, and we were able to get the diagnosis. So a couple of points about SPEN tumors. These tend to be younger patients, females. They tend to be solid and cystic tumors with varying degrees of hemorrhage. This is kind of a classic SPEN tumor. It's got a claw sign with the pancreatic tail. It's cystic and solid appearing. On CT, it's harder to see the hemorrhage, which is why the MRI clue was the T1 hyperintensity. And these actually, even though they look large and very gnarly looking, they're actually 85% of them are benign, and the patients do quite well. One of the reason that they bleed is because they have these pseudopapillary fronds. That's why they're called pseudopapillary tumors. So they have these fronds that have these delicate vascular channels within them. And as they grow larger and larger, they outgrow those vascular supply, and they tend to bleed as they get bigger. So here's an example on MRI of a SPEN tumor. It had this like more fluid component and a more solid component. On the pre-contrast, we can see that fluid component is mostly T1 hyperintense, so there's a lot of blood centrally, and then the enhancing fronds are in this peripheral area. But a couple of caveats about SPEN tumors is that we always say it's young females, it's in the tail, so that's what they like to do, but that's not like that totally reliable. So here was another SPEN tumor. So one of my teaching points is that when they're smaller, they actually can have this smudgy enhancement and don't look as cystic and solid because they have not outgrown those delicate vascular supplies. And then this was a SPEN tumor that was cystic and solid tumor. It was in the pancreatic head and it was in a male. So although I think 80 to 90% are in females, that means that still 10 to 20% are in males, and they're not always in the tail. So even if you see this in the head, it could still be a SPEN tumor. One of the differentials we thought about was a mucinous cystic neoplasm. The mucinous cystic neoplasms are much more reliably based on demographics and the location in the pancreas. So these are almost exclusively females and frequently middle-aged females because the ovarian tissue is touching the pancreatic tail during development. They have a capsule, so they'll have a very nice border, whereas the SPEN tumors can be lobulated and not have a capsule, and that capsule will have ovarian stroma in it. And it can range from being very simple appearing, almost mimicking a pseudocyst like this one, to being much more complex with like locules and true enhancing septations. But it'll almost always be in the tail, and it'll almost exclusively be in women. Unlike SPEN tumors, it can really be anywhere, and it can be in both sexes. And then finally about pancreas biopsies. So we do them. We tend to do them after the patient has had 2 negative endoscopic biopsies because we want to minimize the risk of seeding. You can do it straight into the lesion like this. If it's an uncinate lesion or kind of more posterior, you can go retroperitoneal here. From this paper about CT-guided biopsies, they found that there was a greater than 95% diagnostic accuracy, but it's better when you do a core biopsy than if you do an FNA. And seeding is now thought to be rare if you're using a coaxial needle. And then you can also do, for example, this is the one we did it transhepatic, you can do it transgastric, and you can even do it transcaval. So those are all viable approaches. You definitely don't want to go across the colon, and you want to try to avoid the small bowel. And of course, you always want to avoid SMA, SMV, or any other vessels. So any questions?